good morning, good afternoon from
Good
wherever
evening.
you are joining us. Good evening. I welcome us all to today's webinar. Today we are having a topic that says perioperative patient safety and communication in low and mid-income countries. As we all know, effective communications within and between all phases of the perioperative care and the proper transfer of all patient information at all patient transmission points, including but not limited to using checklists, is very important for the elimination of errors, for improvement in anesthetics and surgical practices, which has resulted in significant reduction in complications, thus ensuring patient safety and quality of care. Today with us, we have Dr. Jackson Ndekezi with us to do justice to this topic. So I would want us to join me in welcoming Dr. Jackson Kwizera Ndekezi. He's an MD, MMEd, and a consultant anesthesiologist at King Faisal Hospital in Rwanda. He's also a fellow in knowledge translation and chronic pain management. Dr. Ndekezi is also a dedicated educator serving as a lecturer at the College of Medicine and Health Sciences at the University of Rwanda, where he also holds the position of acting program director of the anesthesiology postgraduate program. Additionally, he serves as treasurer of the Society of Anesthesia and Critical Care Physician in Rwanda. Dr. Ndekezi's expertise spans through patient safety, safe anesthesia practices, and chronic pain management, making him a valuable speaker for today's TORG webinar. Dr. Jackson Kwizera Ndekezi is not only a distinguished medical professional, but also the chairman of the TORG Rwanda chapter. His leadership and expertise in anesthesia and critical care make him an invaluable asset to our community. Please, once again, I want us to welcome Dr. Jackson Kwizera Ndekezi, whose insights and expertise will undoubtedly enrich our discussion tonight. Please welcome, sir, to today's webinar. You can have the floor.
Thank you so much. I hope everyone can hear me clearly. And I'm so sorry there will be some of the coming other voices outside because I was on my way back home from Kibuka Sati on the other side from the north of our country. This is in terms of commemoration against genocide against Tutsi. And so I'm on my way back to Kigali, the city of the country. And to make things go so quick, as you introduced me, I think it's gonna be so quick. We all work in our theaters, but again, we need to go out see patients before they come into theaters, and after they've undergone surgery, we again go outside of theaters and then see them into the post-op. I'm gonna share my slides, so make it so quick. Can you see it?
Not yet.
Not yet. Yeah. Okay, now. Global aims to improving theater and theater efficacy, efficiency, and safety among the perioperative team. And with that,
can't see the screen yet, if you don't mind.
I'm trying to connect to share my slides. Sorry.
Okay.
Can you see it now? Not yet.
No, not yet.
Not yet.
Yeah.
Now you can see it?
Think it's coming up? Yes, we can.
Okay, great.
Thank you.
So I hope you're seeing it very well.
Yes.
I will not take much time to introduce myself as Mrs. Ndekezi introduced me clearly and very quick. And to be quick, this is where I was born and where I grew up till now where I live, and I feel very happy to stay in. So some of the pictures are really very splendid to see. This is the Kigali Convention Center that hosts most of the conventions or the conferences, international and national conferences that are being hosted by our country. And we have our new forests. And then you can see why we call Rwanda the a thousand hills country. It's got hundreds, mountains, and hills everywhere from the south to north and from east to west. And I wish to see you next time if you're willing to visit Rwanda. And to be quick, what we're gonna be covering today, it's all about how our perioperative care is being delivered to our patients and what we really need to know if we are caring about our patients. It is not about healthcare providers. It's all about whoever is involved in caring all the patients that we are operating on. And we are going to see the overview of what is the perioperative care and why is communication really needed into this period. We're gonna cover why the perioperative care matters to anyone who comes to us. And then we're gonna see what is an effective communication, what are the challenges to make it happen, and what are the strategies to achieve a very good communication into this perioperative care. And then, as I said, we need an inclusiveness in doing this job. At the end, we all know we do not do harm to our clients. And then we're gonna see some of the take-home messages. So as I said, the perioperative care is a kind of complex care that we give to our patients. It is got the care that we need to give to our patient before they enter our theaters, the operating theaters. There is care that we give to our patients when they are into our hands, into the operating rooms. And there is care that we give to our patients when they are into the post of post-operative status and all the way to enhancing a very good recovery. But again, in combining the two phases, we will need support team, we will need maybe the administration of the hospital, we will need pharmacy, blood bank, we will need finance, we need educators, we need social workers. as the TORG always aims to have all this team around. And with that, you always need people who are really well trained, well shaped to be having all this. So in the pre-op, we need to prepare our patients. But what is the preparation that we're gonna give to our patients? Here, I'm going to share a very short story that happened to me recently. A patient whose kids had tonsillitis. Tonsillitis is just swelling of the tonsil. The tonsil, these are immune or lymph nodes that are inside our oral cavity, close to the airways. They get swollen due to inflammatory processes and the response to the infections, or sometimes the immune response to what comes into our body. So the tonsils are swelling to the point they may obstruct the airways or impair the breathing patterns of the patient. So the mom brought her daughter to the hospital at arrival to the emergency, but as the history that the kid had flu-like symptoms, and then what the nurse at the emergency told the parents was really interesting. She told the parent that having flu symptoms and get anesthetized equals to death. Quote me well. Having flu-like symptoms and getting anesthetized equals death, which means when you get anesthesia having flu-like symptoms, you're gonna die. Do we really get all the patients with the flu-like symptoms, even though active symptoms, dying? No, not really. And the caretaker immediately went out, getting out of the hospital, and said the anesthetists always kill patients. That's the kind of communication I need to address in this pre-operative care that we give to the patients. So the patient, when they come to the hospital, they get a pre-op clinic. Either the surgeon gonna receive them, meet their anesthetist, meet whoever that is needed, patient educators, some social workers, and sometimes you need finance people that are going to these things that we are not talking to today. But at the end of the day, they will get to the anesthetist who will examine and the surgeon and then discuss what to do to the patients. And then at the end of the day, they're gonna schedule the day to do operation. But the way we communicate to them is really embarrassing. We need to address this in our low and middle income countries, or in dealing with how to communicate, what to give to the caretakers and what to communicate in the case, so they get the real information before they get into surgery. So I need you to take like 15 seconds looking on these images. And then you're gonna come to the comments and then write some comments, what you think happens into the OR, what the patient think about us when we think tomorrow gonna be your day for operation. Get to the comments section, write something like a comment on this image. 15 seconds. I don't see people writing. Maybe some chats are coming, and yeah. some people are saying, who can see your messages recording and going down. Surgeries, Bratos, Kare, yes, we see. Yeah. These are two different eras depicted. Yeah, that's what happened. That's what happens when we just telling people that we need to operate on them. Our patients fear seeing our operating theaters, and sometimes they do not know what happens when we do not communicate. And they may think that maybe anesthesia may be throwing a very big stone on their heads or killing them. So if there is no communication on the other side, the surgeon may be thinking that he's not going to be doing so well. On the other side, if you do not communicate, you're doing CPR. CPR means cardiopulmonary resuscitation, which means the patient is dying, but you still need help out to rescue the heart pumping. So what do we need? Miscommunication or unclear instruction that can bring challenges that mainly happens. This may be mainly to stress, something like anxiety that comes into our way. But when we do not get real message and the real messenger to transmit the real information. So this will lead to delays into diagnosis when we do our pre-op clinic, misdiagnosis, mistreatments, and sometimes you give wrong medication because the patient didn't really give the real message. Second is the disease progression or complication may be coming our way when this is on the side of our patient. And as I said, you may get at the start of giving wrong medication. And when it comes to anesthesia and maybe acute medicine specialties where you just need to be working closely in a delicate moment to save someone's life, you need to be having a very good information, reacting on real time, and get what you should be getting and provide it to our patients. In anesthesia-related complication, that's what happens if you do not get the real information. That's where you just get the patient in the wrong time. Intraoperative errors that are commonly occurring, that we know them. Instead of giving like morphine, you're gonna be giving micaine. You may get surgery on the wrong side. It's so about communication. And at the end, our patient will be get unsatisfied, will lose confidence on us. So, and the patient's psychological well-being again is affected. That's something we need to address. Again, take some seconds, look at this image. When I get out of my home, the gate is closed. Someone says when they get away from their home, they leave everything closed. If there is no one to stay at home, you are saving someone's life, but if you do not speak up, your information is closed. But how can we address this gap? That's something we need to do. So to address this gap, we need to get some strategies. The strategies will be getting everyone into the perioperative team on the same page and work on patient safety. Why patient safety is a matter. Patient safety is a matter in terms of having everyone on the same page, knowing this can take someone's life, this can be killing someone, this can be eroding our trust into the medics, into the health system of any country. This can be eroding our trust in any NGO that's really partnering with the Ministry of Health at any level, at any country. So the other thing is optimal patient outcome. We need very good outcome at the end of the day. And then you need the team to be collaborating, getting like a team spirit. The other one is enhanced patient experience. Do we do kind of survey that are looking after patient satisfaction after our daily activities? Have you ever done any survey? Asking patients what they think went so well, what were the challenges? And after that, we need to manage the risks. Risk management means you just go all the way, mitigate risks associated with our care that we'll be giving. And then remember, at the end of the day, there is legal and ethical consideration that we need to address. Maybe in some countries, there is no way. Some of the patients are not really suing medics for their, let me say it, unprofessional behaviors or some errors that are made into our daily life. But what comes over now, everything is on internet. They go and read, but when you give the wrong things or just went the opposite way without communicating them, they're gonna be suing you. At the end of the day, we need to keep the continuity of care. We need a seamless transition of care that really, maybe an anesthetist is giving this medication, but again, at the end of the day, in post-op, the surgeon may be on the same boat and receiving the patient for post-op care. The nurse should be having a very good handoff that really gives her the information that will keep the patient safe. What is the way forward? I was really highlighting what happens and what are really waiting for us to be addressed as the perioperative team. We've been observing something being done in our daily activities. What do we do? What are the actual activities that we're doing are really troublemaker, or they are just deal makers? And then we need to go into our context. I will not take the care that is being provided in the U.S. and then expect it to be delivered maybe in Rwanda. That's where we're heading, but we are not at that level. But put it into your context and maximize the care that you're giving to the patient. If it is not really fitting into our context, or it is not really helping out, can we change? That's where we change our habits, our daily activities. If we change, now we need to evaluate what we are doing. What we've been doing didn't really deliver. Now, can we change again, return back to the change? Or it is really working, and now we evaluate the efficacy and efficiency of the change that we just put into place. And then we're gonna adapt it if it is really working. After adapting to our system, we go again the same cycle. We observe, contextualize the situation, and then change the system. If the system does not really work, we're gonna change still. We evaluate, come back, and then adapt to the situation in which we are in. As I said, in our setting, we need even cleaners. We need everyone to be on the same page. This is not a one-man game. It's a teamwork. Remember, all of us are there to advocate for our patients. The advocate that we doing is there to help out and get the best or the optimum outcomes of patient situation. So even a cleaner, porter, if you have them into your settings, if you have like everyone who is involved in caring for these patients into the perioperative care needs to know this is an emergency. For example, if it is an emergency, I need to run first to go to the pharmacy and then grab some medication, specifically which medication that have been really handed to him as a message, and then return back so quick so you can save someone's life. What the WHO says, recently in 2022, there were a campaign about medication without harm. That was the global patient safety challenge that was brought out by the World Health Organization. And then it was just looking at all the corners where we can get safety in terms of medication delivered to the patients. Who prescribe? Who should be really observing what the medication does to the patient, and then monitor. After monitoring, you need to write or evaluate what happened and then record. After recording, you need again to return back to the pharmacy, tell them it works, or it had this side effect, or the system is delaying. That's what we know. And then do not leave the patient himself out of the system. You need to have the patient and the public really aware of what is going on. Patient involvement into the organization, reporting by patients, consider what they are reporting, patient engagement, and then the public awareness and medication literacy. We need some campaign then to go down and tell people what is really going on, what are the side effects if this medication has got this. And then the system that we have and the practices of medication that we're giving. That's where comes the non-technical skills that we need in our daily practice. We need leadership and governance. We need to be aware of what is going on, and then involving who prescribe and who really give the medication, who deliver the medication. Medicines and healthcare professionals should be aware of what is going on. Before I go to the conclusion and the take-home messages, is there any question? If you have a question, you can just unmute yourself or type into the chat. Type into the chats any question, additions, or something that you are like your intervention. This is really communication to the perioperative care mattering. Questions? If there is no question, into the chat, Stera Yao, if I just pronounced it so well. For the audience, what are the biggest communication barrier you notice in your? Yeah, that's a very good question actually. Can we answer to the Stera Yao's question? That would be a very good one. Going back, someone said, anesthetist or anesthesiologist looks like one's gonna kill patients when there is poor pre-op messages. Yeah, that sometimes that happens, but again, the way we need to communicate and the message that we deliver to our clients.
Hey Jackson, may I intervene?
Go ahead.
Okay. My name is Gaston. I'm an anesthesiologist from Rwanda, and I thank you for the presentation. That's a very good one, a very good presentation. And I will start from, I was about to ask a question about how do you guys handle the hierarchy in your practice? And this comes to be like an answer to the question, ask how people manage the communication, what barriers, challenges. One of them is hierarchy. How can a surgeon, how can a student communicate well with the surgeon with hierarchy? How can a simple, like a newcomer, like a nurse can communicate well for the patient safety, for everyone's safety, to the, I would say, arrogant surgeon or the surgeon with hierarchy or anesthesiologist or a senior nurse? How can a learner talk to the senior in depending on which area you are? So I think hierarchy is one of the barriers. So, and then of course, lack of trust and lack of confidence, of course. If someone doesn't have any confidence, then it will be difficult to communicate well because maybe he thinks people will laugh at him or her, things like that. So then the way forward, how can we overcome that big barrier of hierarchy in our settings? Mostly in LMIC, that's where the hierarchy is. And the surgeons lead the OR, it's rare where the leadership is shared with anesthesiologists, nursing, things like that. Maybe the more discussions I'm expecting from other people to share their experience. Thank you. Over to you.
I can see some of you guys were talking about no teamwork or sometimes the lack of trust. And Stella said for us, I noticed that everyone is lashed, so sometimes communication hasn't taken place when it should. And I think these are all the challenges that we have during every day's activity. But what is really mattering is someone's life. I always tell my colleagues that assume this was maybe you who needs care, or assume if this patient was your sister, let me say, if this patient was your brother, would you be allowing anyone rushing without communicating what's really going to happen to your relative, close relative? What would be happening? You would be stopping everyone, telling them this time is not a matter, but what matters is someone's life. And what we're going to be working on, someone's life should be really coherent, smoothly delivered, and communicated to everyone so everyone is on the same page. So Stella asked, how do you create a culture where it is okay for people to communicate openly? I like this though, but it has a very big impact on what we're doing. If someone really does not really get fear of communicating what is happening, it's really very good. It can save someone's life. And here you need a brain language. Brain language means a very good communication skill that helps everyone on the same page to know what is really happening, what matters most, what should be very necessary before the other things. And prioritizing would be very good to anticipate what happens before the others, what happens first before others. And openly speaking to others, we again break the barrier to where Gaston equated on hierarchy and everything that comes our way. It really happens to save someone's life when you openly speak up. Don't be shy, speak up. If you're seeing that the vital signs are really not working, or someone is going to give anesthesia without materials, or you're seeing that your most high professor is going to give Marcaine IV to someone, will you really fear to speak to him that this is Marcaine? And you know what happens when someone gives Marcaine? There is cardiac arrest. Speak up. I personally like the open-minded people to openly speak. And someone said, how to teach students and new staff to speak to a superior practice with a preceptor using a formal communication format like SBAR, also having a new person speak to the superior while the preceptor teacher is by their side. I really like this. It's really a way of having some frameworks that helps to communicate clearly, not missing anything behind. These are the framework that we put down with some organizations that are helping out to beef up our care and safety of ourselves and safety of the organization that we're working for. Any other question? So if there is no other question, what are your take-home messages? You can go into the chat again, write down your take-home messages. What is a very important message that you can pick from this presentation? You can go into the chat. Someone said communication remains the key to patient safety. Patient safety is a key. I like this. This is very important. Importance of communication. Communication can have a big impact on outcomes for the patients. I like this. Thank you, all of you guys. And another take-home message, barriers and how to solve them. On this matter, you can even sit up, then tell people to go outside and then discuss. Adequate communication into the operating room. So without taking too much time, these are my take-home message. As all of you said, safety for all the operative team, safety for our patients, safety for the system. Quote me well. The system, I mean the hospital, the organization, or the NGO that works into health provision is paramount. You need to know your options, make informed choices. And remember, as all of you said, our voices matter. Speak up, stay informed. Clear communication keeps you safe. And remember, don't leave anyone behind. Everyone should be informed. And this marks the end of my presentation. Thank you very much. In Kinyarwanda, we say Murakoze. This is our native language, Murakoze.
Thank you so much, Dr. Jackson. Murakoze, if I know how to pronounce that. I'm trying to learn that. Thank you for that presentation. It's been very, very interactive for what I could pick. And then communication is very, very important in the operating room environment, not just in LMICs, in developed and developing nations as well. Things are really happening, like Stella said. I know Stella is in the US, and if she's saying that people get rushed, so that means, literally means that it's happening all over. Sometimes even the surgical safety checklist is rushed. The anesthetic team wants to start on time. They want to do the induction. They want to do this. They kind of rush everything, and sensitive information could actually be missed as well. As you said, we all need to start speaking up. It could be us. It could be our relative. It could be someone. We wouldn't want to go down the legal route in case if anything happens. And at the same time, on staff communication, I've been involved in a case whereby the staff nurse was actually new. She was meant to be the scrub nurse, and because she is Spanish, and she couldn't, when the surgeon was asking for the instrument, she was struggling to actually pick the names of the instruments. That's another kind of communication in terms of language barrier. She knows the instrument, but she knows that in another language and not in the English language. So when they started, it was a complicated case, and when the surgeon switched to additional instrumentation that she didn't have on her table, then it became a problem because she was trying to grab, oh, what could this actually mean? It became an issue because even after the case, she had to sit down, she had to list everything, she had to do more training and retraining on learning instrumentation, especially what it means in Spanish, what it means in English. So language could be an issue as well. And as we all know, the operating room environment is very volatile in the sense that maybe on the wards, there could be a doctor seeing a patient, there could be a nurse looking after maybe so many patients on the wards, if you know what I mean. But in the OR environment, one patient at a time, so many team members get to decide on one patient. So everyone gets to bring their idea on the table just for one person. So there could be communication issues if it's not addressed properly. I've seen a case whereby it was a revision case. Lots of instrumentation was opened. The surgeon at some point needed a second opinion, invited another consultant. Eventually, 3 consultants had to come in, scrubbing for that case. And one of them wanted Vidin irrigation. It was orthopedics. The other one wanted plain irrigation. It became a problem. They started haggling on the table. This was trying to present his evidence because he actually finished from school recently, and the other consultant was an old consultant, and he didn't want to change. So it became an issue. So I think at that point, it's the responsibility of everyone to consider patient safety, to speak up if it's going to be an issue, to try as much as possible to be evidence, to present the evidence if it's going to help the patient, not because it's surgeon's preference or something, or consultant's preference or anesthesiologist's preference, but if it helps and works for the patient and it's safe, I believe that should be considered at that point in time. I just want to say thank you for that interactive presentation. You've shared relevant knowledge. I believe everyone has picked one or two things from the presentation tonight. So I really want to say on behalf of the team, thank you so much. And I also want to say thank you to the Education and Training Committee for facilitating this. There is always a webinar every 2 weeks. I think the next one is on central venous catheter or something like that. And the speaker is going to be from Namibia. That's Dr. Jesse Mumba from Namibia. So, and I also want to say thank you to everyone for connecting. Despite the fact that the time we actually started sending out the notifications very late, but thank you so much for taking the time out of no time to connect. And I want to use this opportunity to say good morning, good afternoon, good night, depending on your time zone. And we're going to see you in another 2 weeks. So thank you, everyone. Thank you, Dr. Jackson. Thank you to the team, and have a nice day ahead.
Thank you.
Bye.
Bye.
Bye.